This week on the BackTable podcast.
I'd say the number one trick in these patients is to ask them or their family member how they do it and to let them place a catheter in themselves. Because I've done that. I've gone down there and I've tried a bunch of different angles, different catheters, and then the patient goes and takes one and just pops it right in. If they've been catheterizing themselves, unless they tell you that they've been trying and they can't get it, then I know it's usually a problem and I may need to scope them and try to figure something else out. But if the patient has been cathing okay, and maybe they just haven't been doing it, they haven't been compliant, or, for some reason or another, maybe they're kind of sick from an infection or something, and one of their family members is used to cathing them, then I will give them a shot at it all day.
Hello, everyone, and welcome to BackTable Uro, your source for all things urology. I'm your host, Dr. Arthi Hannallah. I am a pediatric urologist at Arizona Pediatric Surgery and Urology, and I'd like to take a second to introduce my co-host, Dr. Nicco Passoni, who is a former resident of UT Southwestern, did his fellowship at UT Southwestern in pediatric urology as well, and is now faculty at Texas Children's Hospital.
Hello, everyone. We're kickstarting a series of podcasts on the topics of pediatric urology. And tonight we have the privilege of having Dr. Mauck, who I'm going to let Arthi introduce.
So we specifically sought a guest today for today's episode who has extensive general urology experience and has seen a multitude of patients with a pediatric urology history, so we can bring to light important takeaways, clinical pearls, and helpful management strategies in those in general, and even perhaps subspecialty practice in adult urologic care. So without further ado, I have the honor of introducing our guest today. Dr. Ryan Mauck is an associate professor of urology at UT Southwestern Medical Center. He is a former Southern Methodist University tennis star who completed his medical training at USF in Tampa, followed by residency at UT Southwestern. He serves as chief of urology at Parkland. He is the chair of the Parkland Robotics Committee and was recently selected to be the president-elect of the medical staff at Parkland County Hospital as well. Since his impressive tenure at Southwestern, Dr. Mauck has had extensive clinical experience and practice primarily at Parkland County Hospital, where he has trained a multitude of residents, including Nicco and myself. Ryan, it is so good to see you, and thank you so much for being our guest today.
Great to see you guys, too. A couple of my favorites, of course. I have a lot of favorites, but you guys were definitely up there.
Well, it's so good to hear. Let's start off, Ryan, by how about you sharing what your clinical practice looks like, and specifically what kind of facilities you cover as faculty, and also while you're on call.
I spend about 80% of my time at Parkland, very involved over there. We have a large team of residents learning there all the time. We have a very high volume of all kinds of patients. At least last year, I believe it was the busiest ER in the country. And so we get tons of consults, a lot of trauma, a lot of, patients of all ages. We have a very busy clinic there where we see everything from late stage cancers, early stage cancers, a lot of testis cancer. We see neurogenic bladder patients and a lot of transitional urology patients coming over from children's who are just getting into the adult urology world. And we're happy to see them and take care of them.
So we definitely want to get into more detail about, your patient population that you see at Parkland. But one of the most common conditions and issues that we face in pediatric urology across over to adult urology is, of course, one of the most common emergencies we see, testicular torsion. In your practice, Ryan, tell us about your experience when it comes to handling testicular torsions, especially in patients who are under 18, coming to your facilities, getting transferred to your facilities. Tell us all about that.
This has been kind of a hot topic for me because I feel like there's a lot of urologists out there that decide to send torsion patients off to a pediatric hospital or something and transfer them elsewhere, when we all know it's a ischemic injury that needs to be fixed as soon as possible. And everybody who's trained in urology knows that this is not a hard surgery. There's not anything special about doing a torsion, especially in, 12 or 13 or 10-year-old, anything. So if a young patient shows up at Parkland, which happens, I believe maybe the youngest I've done is 12 or 11. But the last thing we want to do is transfer them somewhere else where it's going to take another couple hours, if not more, for them to actually get the care they need. So at Parkland, our rule is that if anybody shows up with a torsion, they need to get to the operating room. It's a stat case. It's one of the only stat cases we do. And if I have to go down there and roll them back to the operating room myself, I've done that a number of times, and I never feel bad about it. I never feel like I'm going to get sued or anything like that, because just like any other ischemic condition, torsion, time is testicle, basically. And you've got to go and you've got to fix the problem as soon as possible. Otherwise, you risk losing it. And so we're pretty hardcore about treating those right off the bat. And I would recommend anybody, even most general surgeons have to learn how to do a torsion for their board. So if you're out in the middle of nowhere and the only surgeon that's around at the hospital is a general surgeon, I feel like that person should try to save the testicle as well and not spend 4 or 5 hours transferring and give a lot of time for that testicle to be lost, because at that point it's an orchiectomy and you could wait a week and do that. But you really just need to get the problem fixed, and you may still not save it, but at least you did your best and no one's going to fault you for that.
Very good point about testicle is time. And we often think about, the golden 6 hours during which survival rates are the highest, higher than 90%. But we got to think about that the clock starts ticking when the child or the teenager develops pain. And there's often the delay of getting to the ER, getting diagnosed. And if you go to a smaller ER center, and especially if it's like a right-sided torsion, it might be confused with appendicitis. So oftentimes, that workup gets done before somebody examines the patients, and especially in an adult hospital, and notices that the testicle is swollen. So those delays add up with transfer, and sometimes transfer might take hours, waiting for an accepting hospital, a pediatric hospital, waiting for transportation. So if there is the chance and the opportunity to take care of that patient right there and now, all you're doing is helping that child maintain both of his testicles.
I've seen a lot of these, and I can tell you that not every patient's the same. Not everybody has 8 hours. I think that you see some of these that are twisted 4 times, and if there's zero blood flow to the testicle, then it's going to be quicker than that. I've seen some of them where it's just twisted once or a half time, and those patients sometimes will have pain for a day and a half, and then you still can go in there and save the testicle. So there's no set time, and that's why I think it's important to treat them all like it's a complete ischemic episode, and go and get it detorsed and see if it's going to survive and give it the best shot to do so. And then everybody feels better in the end about it.
With regards to saving or not the testicle, because oftentimes we tend to think, well, you lose one testicle, you've got the other one, you're going to be fine. And indeed, there is plenty of literature that shows that after a torsion, when you save the testicle or not, the chance of paternity rates are the same as the average population. But there's also a decent amount of literature that does show that even in the case when you save the testicle, there is a fairly non-negligible rate of contralateral apoptosis of spermatogonia in the contralateral testis. So there might be some sort of mechanism that leads to decreased fertility rates, kind of like when you think of varicoceles, why does left-sided pathology with varicocele affect fertility rates, even the contralateral testicle. So it's not just a matter of saving the testicle, but also potentially maintaining fertility for these patients.
Certainly.
Ryan, in your experience, have you come across any issues when it comes to expediting these patients to the OR in a non-pediatric hospital, whether at Parkland or any of the other hospitals that you cover?
We actually had this discussion in some of our surgical executive committee meetings at, which types of cases needed to be considered stat. Because you always run into the problems where people want to post stat cases because they need to get it done and off their schedule quick or things like that. And you have to kind of police that at some level. And when we started talking about torsion, I was just pretty clear that this is an ischemic. It's, they say it's got to be life or limb, and it's not officially a limb, but it is a testicle, and it's a time sensitive situation. And so everybody pretty much agreed, and I think would agree at any institution if you frame it the right way, that this is something that if it's your testicle, you'd want to give it the best shot of surviving. And so we don't have a lot of stat cases in urology. I mean, I think Every once in a while, people will try to put a septic stone on as a stat case, and I don't feel that that's quite as necessary as a torsion. I think if you do that within an hour or two, then you're doing the best you can there and probably not affecting things too much. But with an ischemic episode like torsion, I think that you really do need to get them back there as quick as you can. And my belief is that it fits the definition clearly of a stat case.
And considering barring, any issues postoperatively from anesthesia, the patients very rarely at all need to be admitted overnight or be observed or anything like that. And so they usually end up going home. And so even if you're at a facility where maybe if you don't have admitting privileges per se of a pediatric patient, it is something to be mindful of that, as long as they're otherwise healthy and it's something that you're comfortable with and, there's not going to be an issue from a hospital credentialing, anesthesia credentialing standpoint. It's definitely something that can be much more beneficial, not just to the patient, but, to the community systems involved as well. And the resources that it takes to transfer a patient. I mean, it's like, 4 times more likely that they're going to be, I think it's the amount of money that they spend on a hospital transfer, I think is 4 times the average amount of someone just coming to a hospital and they're getting their surgery in the same facility.
Yes. And one caveat to that, I will say, is that if the patient has had a torsion or had pain for a couple days or for a day and a half, and they're already starting to get some edema in the scrotum and there's no flow, in that scenario, I've found that if they're already starting to get scrotal changes and everything, that usually tells me that the testicle is probably already dead and we don't need to do that orchiectomy stat. But, it's kind of, that's why in these patients that have had pain for a little bit longer period of time, I think the exam is really important. It's important to know the whole story behind it and make a good decision on whether you really need to take that patient stat. In the acute torsion patient, usually the scrotal skin is still normal. They're having a lot of pain. And whether it's been 8 or 10 or 12 hours or 4 hours, I really don't care. That patient, I'm taking them to the OR stat.
Yeah. I tend to push the limit even further than the 12 hours, just because sometimes there's this intermittent torsions, like, you don't know, it's like you don't want to be the urologist that decided, well, I'll wait to add him out at the end of my clinic day, and then all of a sudden it's been more than 24 hours and the testicle is dead, when maybe you could have salvaged it, if you've got the time and the availability, add him and take care of it as soon as you can.
Well, that's what I'm saying. I did one not too long ago that had been over 24 hours. The story sounded pretty classic for a torsion, but there were still no scrotal changes. It still actually seemed like it might be salvageable. And it was one of those that, like I said, had very minimal twisting. And it was just the testicle was angry and ischemic, but not completely cut off from its blood supply. So I think in those cases, that's why the physical exam and kind of hearing the story and all of that is very important. And not every case is the same. But that patient we took stat, even though it had been a longer period of time, mainly because of the exam. And what the patient was telling us sounded pretty classic for torsion, and it seemed like the testicle might still be alive.
And also, I think it's important to be mindful of, certain best practices. Like if you have a facility, without any urology coverage, sending you a patient where they manually detorsed it and they're asking if they can send the patient home or send them to you. Is that, something that you've come across, or people who feel like it's torsion based on an abnormal lie, but they haven't gotten an ultrasound yet? These are common things that we come across in pediatric urology, kind of very heavy exam, kind of historical findings, but maybe not necessarily an actual ultrasound result that has demonstrated torsion that will define, a stat case into the OR. So how do you kind of handle those types of calls and questions when you get them about sort of these more historical, findings when it comes to torsion?
Well, I think that somebody who had a torsion and was manually detorsed is kind of a different story than somebody who may have had a torsion but had flow, and you think it might have been an intermittent torsion, but you don't really know. And so the patient that had to be manually detorsed, I'm pretty worried about that patient, and I would probably plan to do an orchiopexy on that patient in a relatively short period of time. A patient that you don't really know if they had a torsion, and it may have been an intermittent torsion or may not have been an intermittent torsion, what I usually do is try to talk to the patient and the family and tell them the importance of them coming in right away if they have testicular pain, so that we can try to fix it. And I think that, I don't want to do an operation if they never actually had a torsion. But at the same time, I think they need to know that, hey, your testicle could die if you don't get in right away. So if this happens again, you need to come in immediately and we need to take care of it. And I think those are kind of two different scenarios. If someone actually had a twist and somebody untwisted it, which is very hard to do, they're usually in a ton of pain. So I would say that it's very rare that someone actually successfully detours the torsion in the ER. Extremely
Completely
rare.
agree.
Yeah.
Very, very
Has
rare.
to be within the first couple of
Yeah.
hours when that edema isn't set in.
Mhm.
Right.
Otherwise, it's going to be extremely painful and impossible to do. As the first episode on pediatric urology, we thought that would be very useful for our general urology listeners to discuss kind of like common situations that every general urologist should know about patients that have either pediatric urology, history of pathologies and surgeries. And we decided to have a more practical approach, kind of discuss possible common intraoperative consults that an adult urologist might get called for that have pediatric implications. And we do realize that Arthi and I, both as practicing pediatric urologists, we might be biased. And I do recognize that the adult urology population tends to have much different problems than what we see every day. But every now and then, the adult urologist, the adult practitioner might encounter a patient that has a history of pediatric surgeries. So that's kind of the spirit of the next section. And we could easily start off with fairly rare, but very high risk complication that has a 1% mortality. And that is a patient that had a bladder augmentation and presents to the ER with concerns for rupture. We want to ask you, if you get a consult from the ER, what are things that start running through your head? What are things you're going to ask the ER to do? Potential exams, labs, and overall how you approach this patient.
That's one that gets us all kind of nervous, of course, in general urology. Out in private practice, I'm sure you probably don't see a lot of ruptured bladder augments, maybe haven't seen what that looks like since residency. But what I will say is that I like to try to immediately find out how sick the patient is, because I know there's good literature to show that a lot of these patients can be treated conservatively if they're stable and, with adequate bladder drainage and a drain potentially. And I think that's the way to go. If you have somebody that's not really that sick, that their electrolytes aren't out of whack, their lactate is in the normal range, and they're not, somebody who you're really worried about going to the ICU, that you could just monitor on the floor, that kind of thing. Unfortunately, that's not always what we see. I've had patients transferred in that are really, really sick, that have ruptured augments, and it's definitely a scary situation. As a surgeon who, I don't personally do a large volume of intra-abdominal open surgery, especially on a lot of reoperative patients. And that's how I'm sure most general urologists are out there. We're not doing cystectomies every day. We're not doing RPLNDs, and we're not doing redo surgery. So the way I look at these is, if the patient is really sick, they have a ruptured augment, I'm trying to find the best way to go in and fix the bladder without getting into all the disaster of the bowel adhesions and the VP shunt and all of this. And I've had at least two that were really sick of these patients. And I try to, make sure I look at the imaging and know what's going on in their abdomen and try to know their surgical history. And then my goal is to go low and get in on the bladder and try to close all the holes in the bladder. If I have to close some of them from inside the bladder, I'll make a cystotomy and then go in and close what I can from inside the bladder. And then I've tried to enter the peritoneum through, you don't really have a space of retzius intact per se, but a lot of times everything's kind of walled off. So I usually try to get access to the peritoneum through like a peritoneal window type of situation around the bladder, and then suction irrigate as much of the pus out as I can, and then get some drains in there. And I've had success, at least in two cases that I know of like this, that they do get better in the short term with, that type of surgery, where we're not doing a big giant X-lap where we're trying to fight through adhesions and deal with the multiple prior surgeries and everything. And I've had success doing it that way. I think that you want to have general surgery available because you may run into injuries to the bowel in these cases. It's definitely not easy, but if you can get in there and drain the fluid collection, close the bladder as best you can, and leave some drains in a big SP tube so that the bladder is draining adequately, I think that's an acceptable way to handle an urgent augment rupture in a patient that's really sick. Otherwise, I would try to play it conservative if I can, if the patient's stable, and stay out of that field as much as possible. But sometimes you don't have that option.
Yeah, you've hit the nail right on the head. Those surgeries are going to be complex, regardless of the acuity of the scenario, possibly infection, urine in the abdomen, getting back into those bellies, it's going to be tough from the adhesions. You get in, go through fascia, you don't know if what you're seeing is going to be a loop of ileum versus your augment segment, which most of the time is going to be small bowel. Another thing that you got to be very careful when you do this operative case is the mesentery of the actual augmented segment. So last thing you want to do is go in, try to repair the rupture, then accidentally devascularize the bladder augment. But you said it correctly, drainage is going to be fundamental. So going back to the original question, when the ER calls you, first of all, what is your preferred imaging study to decide if there is a rupture or whatnot? Or if the patient is ill, do you take them to the OR right away as soon as possible? Second of all, if the patient comes in without a catheter, most of these patients have APVs, how do you troubleshoot an APV channel? And by APV, just to remind all non-pediatric urologists that are listening, I am talking about a Mitrofanov or appendicoplasticectomy. How do you troubleshoot a patient that cannot catheterize their channel?
Yeah, I think you've got to try to get access there. One question I'm asking is if they've had a bladder neck closure or if they have strictures, because you may have to go from below and get into the bladder. So you can do a cystogram. That's going to be probably the most important study. See how big the leaks are, where they are, because for surgical planning, you want to know, especially if you're trying to close these from inside the bladder, which is what I was talking about in some of these sick patients, that you're trying to stay out of the peritoneal cavity. They tend to have, areas that are very thick, and it's not really always that easy to find the hole when you're in there. So I want to know as much as I can from the imaging. I certainly want to have a catheter in there. If it has to be scoped in, I would try that. But, sometimes if you can get one from below through the urethra into the augment, and then, that will have to do as well.
Absolutely. And then, other things certainly to be mindful of in your imaging is whether or not the patient has a VT shunt, what kind of hardware they have, certainly, what prior surgeries they've had, and also getting a sense if the patient or a family member is able to tell you what they usually use to catheterize. Because, a lot of these patients, especially as they get older, they may have issues, obtaining catheter supplies, they may not be as compliant, understanding where they were at a baseline to begin with, I think is also very, very crucial, because some people, they may not just be using their channels at all and may just be going from below. And so just like you said, Brian, making sure that you're getting an adequate history, which can be difficult, especially if it's the middle of the night, you're getting called about a patient getting transferred to your facility because you are the only nearest urologist in your community, understanding any sense of what kind of tubes, if any, the patient already has or utilizes, and their shunt status is absolutely crucial when it comes to bringing these patients to the OR. And I think one thing that you mentioned that is so important is loading the boat. Even for us as pediatric urologists, these cases can be really, really daunting. And many times we end up having to do a lot of these cases too with our pediatric surgery colleagues, neurosurgery. We also, as your former residents, have personally been involved in some of these cases that we can recall. When do you sort of feel like as a general urologist, you want to start to load the boat yourself with more reconstructive specialty trained urologists too in these circumstances?
Yeah, well, some of that has to do with how much time I have. If this is an emergent case and I'm on call on the weekend, then I've got to figure it out with who else is on call on the weekend. But if it's a patient that I feel like can wait and is doing fine, but does need a surgery and has an augment and has a crazy surgical history, that's somebody that I'm going to talk to one of my colleagues who does a lot of this big surgery on bladders and has a lot of experience going in there and hostile abdomens and such. So at UT Southwestern, I'm sure at every program you have guys that you go to for the hardest stuff. And so, these are cases where, if the patient's really sick and you've got to do something right now, then I feel like you go in and you try to get what needs to be done in a safe fashion and get out. But obviously if they need a big surgery and you have time to wait, then you want to make sure you have the right person doing the surgery. That's usually probably not going to be me, unfortunately.
Some days you're the hero they need.
Or fortunately, I guess you could say.
I just, once again, for our audience, want to underline the importance of getting drainage in these bladders. Bladder ruptures tend to happen because the patient goes for a long time without emptying their bladder. And an augmented bladder tends to be much weaker than a regular bladder. Especially the longer the bladder is distended, the more ischemic it gets, especially at the junction between the detrusor and the bowel segment, thus leading to rupture. So getting access, and what Arthi was saying, asking what catheter and what orifice to catheterize. They might use their natural urethral meatus. They might have an appendicovesicostomy stoma that's hidden in a very deep belly button, or some patients might have two stomas, one for the bladder with the channel and the mace for their antegrade enema. So realizing where to put a catheter is fundamental. Usually those channels accept 10, 12 French Foleys or straight catheters. So using those, it's always the safe bet. Nothing bigger, not your good old reliable 16 or 18 French Foley that you use for urethras. And more importantly, not always you're going to be able to catheterize, especially if the patient with the channel comes in retention. The intravesical pressure might be compressing the valve mechanism so much that you won't be able to advance the catheter, no matter how much lubricant you use. And you don't want to force it, because in that case, you might create false passages. So there are several tips or tricks that can help the on-call urologist try to place a catheter in a patient that has a channel that is in retention and won't accept a catheter. Due to your immense experience at Parkland ER, do you have any tricks that come to your mind?
I'd say the number one trick in these patients is to ask them or their family member how they do it, and to let them place a catheter in themselves. Because I've done that. I've gone down there and I've tried a bunch of different angles, different catheters, and then the patient goes and takes one and just pops it right in. So if they've been catheterizing themselves, unless they tell you that they've been trying and they can't get it, then I know it's usually a problem and I may need to scope them and try to figure something else out. But if the patient has been cathing okay, and maybe they just haven't been doing it, they haven't been compliant, or, for some reason or another, maybe they're kind of sick from an infection or something, and one of their family members is used to cathing them, then I will give them a shot at it all day. It doesn't hurt my feelings if someone else can get the catheter in before I can. But other than that, I think if you can't get one in, then you've got to try to scope one in. If you can, get a wire across and do what you can to get a catheter in there. And if you do have to go in open, like I was discussing in the sick patients, leave a large bore catheter, maybe even a Malacot, suture it into place and make sure that you have really good drainage. And you can leave another catheter in the APV just to keep it open and make sure everything's going there. But I don't mind having a couple catheters in the bladder, including one very large one, to make sure that it's draining adequately as everything's healing.
Consider they will make a lot of mucus, especially after a surgery. So the more drainage, the better it is. And you said it perfectly, ask the patient, because oftentimes these channels have different angles and the patient has been doing it for a long time. So they slide in just like butter. And the last resort, always, like, if you can't catheterize, the patient can, and the bladder is full, it's not yet ruptured, but you're trying to avoid that drastic event, you can always take a 60cc syringe with a spinal needle, suprapubic area, and aspirate. In that case, you buy yourself time, whether it's for a transfer or for figuring something out.
Exactly.
whether you're using a cystoscope to scope it in, or even sometimes a flexible ureteroscope can be helpful as well, especially if you're sort of in a dire situation and the patient's had some sort of bladder neck reconstruction. You're not sure if you can get anything from below. Sometimes using a flexible ureteroscope at the bedside, or this in the OR as well, can be helpful. I've actually found that especially some of my patients who are ambulatory, who catheterize, and they come in these types of situations, having them stand up or sit up can actually be helpful when it comes to capping them as well. Because, they're all laying in a gurney or a stretcher, or they're, in a room in the hospital, and there's supine the whole time. And that can also affect how you're able to easily get a catheter in as well. So sometimes just repositioning the patient as well can be really, really effective. So, yeah, and kind of other sort of issues that we face and, other sort of cases that we find crossing over into the adult side, because we have so many patients in the pediatric population who've had vesico-ureteral reflux, who've had reimplants or deflux, and they're thriving and they make it to adulthood, and they may end up in the emergency room with a stone or with pyelo, and they may have some hydronephrosis. These are all kind of little nuances that, unless you know their medical history, you may be mistaken in thinking that these are abnormal. So kind of thinking about this in the broader perspective, Brian, tell us about any kind of experiences you've had when it comes to patients who've had ureteral reimplants, specifically cross-trigonal reimplants, prior UUs, deflux, who presented to your hospitals either with a kidney stone, ureteral stone, or, pyelonephritis and hydro. And if these are kind of experiences you had, we'd love to hear more about those.
Yeah, well, with the deflux thing is interesting, because if it's a UVJ stone, about, 2% of the deflux patients will calcify their deflux. So it's not actually a UVJ stone. So you may get kind of fooled there in a reflux patient and think that they have a stone when it's really deflux there that's calcified. I honestly haven't come across that much. I believe I've seen that once maybe. And, the patient wasn't really sick or anything, so fortunately we didn't have to go put a stent in or anything like that, but it can be something that can complicate things, because you don't really know if they're obstructed or not. They may still reflux a little bit and have a little bit of hydro there, and you don't want to end up going and trying to do a ureteroscopy on that. So it's something definitely important to know about their history. The cross-trigonal reimplant is difficult, but it's definitely possible to do ureteroscopy in these patients. I tend to use a angled glide wire, and maybe even an angled angiographic, or like a Cumpy type catheter to get the wire up. But once you get the wire up, you should be able to even get a small access sheath in there potentially. I wouldn't try to go too big with that, and I would make sure it went easily. Or you can just drive a scope up over a wire and treat stones that way with a cross-trigonal in there. And, haven't had many problems with that. But it does, you do need to know that it's going to be a little bit more difficult to get access to that ureteral orifice in those cases.
Absolutely. Always very reasonable to do a retrograde in these circumstances, just so you get a better sense of the anatomy beforehand, especially if you come across, some tension, some pressure, you're just not sure if you keep pushing. You don't shy away from doing a retrograde in these circumstances.
Certainly, yeah. And you need to be a little bit more careful, obviously, because you don't have a great angle when you're pushing or advancing an access sheath, for example, or a scope up there. So you really have to be a little bit more careful. I like to use like a glide wire in that situation, and then get a stiffer wire, like a double floppy, an extra stiff or an ultra stiff up to put the scope up over. But I think ultimately you can still treat those patients. You just have to be aware of what you're dealing with and kind of going with the right equipment. Have you seen these calcified deflux that pass as stones before? And, I would ask you, what's the best way to rule that out? If you see what looks like a stone down there, they had deflux.
History.
Yeah.
And I've known that, talking with some of the reps of deflux, they are starting to hand out cards to the patients, kind of like wallet-sized cards that have a picture of the appearance of this on a CT. So if the patient were ever to get a CT and the report says there's stones in the UVJ, like you said, there might be some residual hydro, whether it's because that high-grade reflux or because they still have reflux. There you have it. But it also can be like, I can see a young patient with that had deflux, they still have persistent reflux, they get pyelonephritis, they get scanned with a CT in the ER. It's like, oh my gosh, there's an obstructing UVJ stone. Then you mobilize the OR for a stent placement of a stent in the middle of the night and, just pile on a patient that has deflux. But they're not as common, but it's something that when I counsel patients, I tell them beware that this might appear as a calcification on future imaging.
And similarly, when it comes to common pediatric conditions like reflux, I see a lot of patients with prior EPJ obstructions who had surgeries, done by pediatric urology, most commonly a pyeloplasty. When you see these patients kind of transition to adulthood, PCP gets a renal ultrasound and the patient has hydronephrosis, or they had some flank pain or something, and they're getting some imaging and they have some residual hydronephrosis. What has been your experience in terms of practice when it comes to following these patients? Do you find that following them long term has been helpful at all? What do you feel kind of happens to them as they get older, and where do they go?
Well, a lot of it depends on when their last imaging was. Well, first of all, are they symptomatic? If they're not symptomatic at all, and the surgery was done a long time ago, and I try to find any old imaging I can find. So if I can find a CT from a year ago, 2 years ago, 3 years ago, and it all looks the same, their creatinine's normal, I'm not going to get too concerned about it. But, if this patient's coming to me and I don't really have any of that information, and all I know is that they had a pyeloplasty a few years ago and they have hydro, my first step is going to be to get a renal scan and see, one, what the drainage looks like on that kidney, and two, what the function is. If the function is slightly lower than the other side, I may want to get another renal scan in a few months just to make sure that they're not losing function in that kidney, even though they're asymptomatic. If they're losing function in the kidney over time, then that would, give us a reason to get a little bit more concerned in that patient. But if the function is 60-40 and it remains 60-40 at 3 months and they're asymptomatic, I'm not too concerned about that patient either. So it just kind of depends on how many data points we have after the pyeloplasty. Most patients that fail a pyeloplasty are going to be symptomatic, but not all patients. If they're symptomatic, you kind of know what to do. You're going to go the next step and see, do we need to balloon dilate or try to get a redo pyeloplasty? And, you're going to go down that pathway, but it's the asymptomatic patients that you're worried about them losing function over time that create a little bit of a challenge. And I think doing a couple renal scans in a row to look at the function and see if they're losing function is really the only way to tell if that's going to be concerning to me or not.
Definitely. I mean, even us as pediatric urologists don't necessarily follow these patients their entire lives if they had a pyeloplasty done as a baby. And I would say the average pediatric urologist tends to, correct me if I'm wrong, Nicco, follow these, into kind of early toilet training, school age years, and as long as the ultrasound sort of looks stable and patients not having any progressive symptoms, we kind of start liberalizing following up with them. And so even, within our cohort, it's not necessarily something that we follow with annual ultrasounds or renal scans or anything like that. And so, it's more so what prompts the patient, right, coming to an adult facility, whether it's an incidental image, symptomatology, all of those things ultimately matter.
I've never really felt like the annual ultrasound in these patients is very effective because it doesn't really tell me what I want to know. They could have a slightly increase in hydro because they just drank a large sweet tea from Whataburger before they got their ultrasound. It doesn't tell me function. It doesn't tell me drainage. It really just tells you if the hydro is a little bit worse or a little bit better, which could fluctuate based on their fluid status or a lot of other things. So I'm not in the camp of wasting time personally on repeat ultrasounds in these patients. I think that you really need information, and the best information is from a renal scan. And sometimes you need more than one to really get an idea of like which direction they're moving in. And so that's why I kind of lean towards that. And then if everything looks stable, then we don't necessarily need to keep following them with imaging on a regular basis after that, especially if the surgery was a few years ago and everything seems to be stable at this point in time. Then unless something changes symptomatically or something else happens, they start getting stones or something, then I might, start working them up again.
Definitely. And I think that's sort of one of the most important takeaways as these patients, grow into adulthood and, move on with their lives, is that ultrasound is such a commonly used modality in pediatric urology. It's not necessarily invasive, does not have any ionizing radiation associated with it, doesn't necessarily require an IV or, catheters, which is something we want to be very mindful of when it comes to taking care of young children. But certainly as you go into adulthood, ultrasounds alone made more so a snapshot in time, not necessarily a predictor or understanding of function. And I think once these patients, reemerge, into care for any sort of persistent hydro-related issues, the question is not necessarily what does it look like, is there something we need to do about what it looks like?
And then, I'm always going to want a CT scan at some point to make sure that they didn't have a stone somewhere, and that's why the hydro was worse, because these patients do have a higher risk of forming stones. So I'm not going to follow them with CT scans, but, at some point, I'm not going to just want to get a renal scan, and maybe they had an ultrasound a year ago. And, at some point, if it's a new patient to me, I'll probably get a CT renal colic just to make sure that there's no stones there causing problems as well.
I do agree. I always make a point to tell all my families that, to expect some hydronephrosis after surgery, because not every pyeloplasty will lead to a perfectly normal looking kidney, especially those ones that we operate on, which, are not all the cases of like hydronephrosis, but those that have severe hydronephrosis, blown out renal pelvis, blown out intrarenal calyces, thin parenchyma. I compare those to like a plastic balloon. Once you take it out of the packaging and blow it up, even if you let all the air out, it's never going to be as flat as it was going to be. So tell the families, expect always some hydronephrosis. So I usually follow them pretty frequently after surgery, and then eventually go to yearly, and then eventually space it out. And usually I tend to get my last one after puberty once the child is done growing, to ensure that there's no scientific evidence, but the child grows, stretch on the anastomosis, maybe can cause stricture. But if the kidney looks fine once they're pubertal, I tell them, come back if you have symptoms. But I always tell the families, be aware, I always show in the picture, your kidney is swollen. We look at the ultrasound together. So if the child later on in life were to get an ultrasound for abdominal pain, and then there is the read of severe hydronephrosis, I tell them, well, come back to me. We can look at the ultrasounds together, and then we can determine, yes, it is severe. We need to do further testing, which I do agree with both of you, has to be a functional study, because hydronephrosis on ultrasound or CT, it's just a picture in time, versus there's nothing to worry about. That's your chronic hydro that you had since your repair.
I think it's very, interesting to hear this discussion, because I would say, even just from talking with Nicco and, our community of pediatric urologists, everyone sort of has a different sort of methodology or practice pattern when it comes to how long and how frequently they end up following these patients as well. Some people get annual ultrasounds until they turn 18. And so that variability in practice pattern, I think, is reflective as they go into adulthood as well. And I think one of the things that we wanted to highlight, in this episode today, is that not everything, in their children is just cut and dry and algorithmic and as dogmatic as, certain conditions are that we are very familiar with as urologists, such as prostate cancer. And I think it's more so understanding the nuances behind what is bringing that patient in, and sort of what the clinical need is to further evaluate that patient.
We see these patients come in with maybe a UTI, and they have some hydro there. And that's where it gets a little bit tricky, because, you don't want to put a perk tube in. If they don't have a stone, I usually prefer to get them perked so that we can study the system and know what to do with it. Once you put a stent in there, you really can't, until you pull the stent out, you're really not going to know if they drain or what's going on. So if there's no stone, then my knee-jerk reaction is going to be to put a perk tube in a patient that has pyelo or has a UTI. So these patients can create a little bit of a challenge if you don't have their history, because they come in with hydro, and a fever or a UTI, and the immediate reaction is to put a perk tube in. But if they're not really that sick and they've had chronic, what seems like it may be chronic hydro, then I like to give them some antibiotics, admit them to the hospital, and then try to get a renal scan while they're in the hospital. Because if they drain okay, then maybe they don't need a tube and they can just be treated for pyelo. And, we're so scared in adult urology of the septic stone patient. We've all seen these patients crash. So I think you have to sometimes have a little bit of reservation in some of these patients with like chronic hydro who've maybe had a pyeloplasty in the past, and maybe hold off a little bit on putting a tube in them if they're stable, and try to get an idea of how well they drain and is this chronic hydro or are they actually obstructed before you go and intervene on them. Because having a perk tube or a stent is not benign. We've seen that. They come back in with multi-drug resistant organisms when they have perk tubes. The stents, they're miserable with them. And again, once you put a stent in there, you can't study anything. So you're not going to just change a stent every 3 months for this patient. So at some point, you're going to have to pull it out. And I feel like it doesn't really advance us in finding out what's going on with these patients at all. It just temporizes the situation, and the patient may have not even needed a stent. And that's where I feel like, admitting a patient, getting a renal scan in-house, and finding out how well they drain on that kidney can avoid a lot of problems in some of these patients down the road.
Absolutely. I think that's such a great point. Just making sure you understand what is bringing the patient in, what their clinical status is, and not necessarily treating the imaging and letting that guide your treatment plan, but really seeing the whole perspective of what that patient's history is and how that's impacting their current presentation. So I think, as we're sort of nearing, the end of our time together, one of the last things we wanted to discuss with you, Ryan, is your experience when it comes to more outpatient management of some of these patients' conditions, specifically patients who have reconstructed bladders and their long-term management when it comes to catheterizing, UTI management, upper tract management, et cetera. So we would love to hear more about what it's been like for you when you're in Parkland Clinic or outpatient when it comes to seeing these patients who are spinal cord injury, spina bifida patients who've had reconstructed bladders, when it comes to particularly their cath management, upper tract surveillance, UTI management, and so on.
There's a lot of kind of different categories of these patients. The spina bifida population, I think, usually, at least in the Dallas area, gets great care in pediatrics. I mean, they have Scottish Rite and they have great follow-up. A lot of times they have a lot of urodynamic tracings that we can already see. You don't always have that. And so I would say that, most of these patients, especially if they're catheterizing, whether it be an APV or they're, however they're doing catheterization, I like to get a baseline urodynamics on them as they transition. Again, I'm not going to do that if they just had one recently and they're not having any issues, but I don't do yearly urodynamics on these patients. I think that we get a baseline and make sure that they don't have high pressures or anything concerning. And then we really only repeat the urodynamics if they're having a lot of new leakage or new issues. We don't scope them every year. Some people try to scope them every year. Even if they had an augment, we don't scope them every year. We scope them if they start having hematuria, they start having significant abdominal pain, bladder stones, other problems like that. But I think scoping these patients every year actually creates more problems than anything. It's been, shown in the literature too, that you go in there, they're catheterizing, there's edema, there's things that you can't really tell whether it's a red spot or a CIS or something. You end up taking them to the operating room and biopsying things. And, the cysto almost never looks normal. So it's really hard to determine if something's going on. And so I think just keeping a close eye on the patients, if they're doing really well, we follow them yearly with an ultrasound and labs. And, Are you having recurrent UTIs? Are you having a lot of problems with debris? If they're having recurrent UTIs, I recommend, vigorous irrigation of the bladder. I've seen up to 240 cc's for irrigation as being recommended to prevent debris and UTIs. So, I'll tell them to irrigate with quite a bit of saline in there on a regular basis. And depending on how bad the debris and obstruction of the catheters get, irrigate. Maybe you need to do 240 cc's. Maybe you need to do it a couple times a week. Maybe you need to do it daily if it's really bad at times. But irrigating the bladder, and if they have an augment, to try to prevent infections and prevent stone formation. And then, a lot of these patients are just kind of humming along, doing well. And if they're doing well, then I think an ultrasound and labs yearly is adequate.
And considering, general urology, you may have a very busy, diverse practice as you're, in your catchment area. Sometimes seeing some of these patients can be labor intensive, or, when it comes to the logistics of ordering their supplies, being mindful of, their needs outside of just sort of the face-to-face contact you may have as a urologist. And so have you found there to be, opportunities to incorporate advanced practice providers, ancillary staff, when it comes to managing some of these patients as well who are otherwise clinically stable?
Yes. In fact, at Parkland, we now have a multidisciplinary clinic for some of these transitional patients with spina bifida, other spinal cord injuries. And so they have a clinic once a month at Parkland that has neurosurgery, urology, primary care, nutritionists, physical therapists, and it's kind of a one-stop shop for these patients. And we have one of our APPs go over there every month and see these patients. They get a lot of them are new patients coming over from Children's, so they're able to get all of their supplies and everything switched over to being ordered from Parkland as opposed to Children's. So that's a really nice, that's one problem that a lot of them have, is like, where do I get my supplies from now? And it takes them a long time to get into our system and everything. So this way we get everything transferred over. The APPs see them and they know how to recognize a patient that may need to be seen a little bit sooner by us. Maybe they're not able to cath very well anymore all of a sudden, or maybe they're leaking a lot and they think they need a urodynamics right away. And so our APPs have been great at seeing these patients and kind of getting a disposition on them. Are they really happy and doing well? And maybe they just need to be seen once a year, or is this somebody that needs to kind of get in quick and get some imaging and get things moving? So that's been a great addition that happened maybe a year and a half ago or so at Parkland, and I think that's helped a lot. The patients have been happy with it, and I think that's something that a lot of big hospitals could introduce as a multidisciplinary clinic for these patients, because it's a tough thing moving from Children's, where you've been seen by a urologist and a neurosurgeon and all these people over at Children's, and then all of a sudden you're kind of dumped into a new hospital system and you don't really have your neurosurgeon, you don't have a urologist. They're not all on the same page, and I think that's something that's great for the patients. It makes it probably easier for us because they're plugged in, they get their supplies all set up, and they're kind of triaged in the beginning. And so it's something that can really help for the providers and the patients, I think.
And just knowing your resources as a urologist as well. I mean, the Spina Bifida Association has a multitude of resources for both patients and providers when it comes to, general catheter management, recommendations, support. The neurogenic lower urinary tract dysfunction AUA guidelines, I think, have been very, very helpful to incorporate when it comes to transitioning some of these patients beyond, the resource that you have within your institution. Knowing your resources as well as a practitioner is certainly absolutely essential. As we're wrapping up here, Ryan, what are sort of the main takeaways from that you would want, the listening general adult urologists, those are in training, who may not necessarily go into pediatric urology, but maybe looking at, sort of a wide, diverse practice? What are sort of the main takeaways when it comes to pediatric urology history patients?
I mean, I I would just say that, there's a lot that you can do for these patients. You don't have to be an expert necessarily in this area. I think that knowing the basics of what most patients that have an APV or, have spina bifida, knowing that a lot of, for example, you see cerebral palsy patients that they come in and they're voiding into a diaper and large volume voids, and you don't really know what to do with this patient. But just like if you do a little bit of research into it and know that these patients have trouble with CIC, and most of the time it's safe for them to void into the diaper, and if they can handle it at that level and the family can handle it, trying to avoid CIC in these patients because they do have a lot of pain with CIC. They've got very tight pelvic floors, but also knowing what to look out for because they can get upper tract deterioration. They get the pseudo dyssynergia. So you just have to know kind of the basics of what to look out for, and also what specific problems these patients might have. Like that specific population has a problem with CICing. So you may have to put a suprapubic tube in the patient instead of telling them to CIC 4 times a day. But there's not a lot of different types of patients in this category. You've got spina bifida, cerebral palsy, there's hypospadias patients that a lot of times you may have to get your recon folks involved with, but you have to know that they've probably had a lot of trauma with catheterizations and cystos and everything. And so you don't want to just go in there and say, okay, we're going to scope you and do a rug and everything in the clinic and all this. They may have trouble with that. You may want to do your workup in the OR with these patients. And so I think if you're aware of these issues and you kind of read up about it a little bit, you can really do a good job of taking care of these patients. But then the most important thing is knowing like when to get the experts involved, because when it comes to big surgeries on these patients, it's very complicated, and you don't want to be, getting into a mess and trying to go in there on a big operation on a patient who's had a bunch of surgeries as a child and has a VP shunt. I mean, it can really be a complicated situation. So I feel like what you have to know is you have to know when to be scared and when not to be scared. And most of the stuff is pretty easy and you don't really need to be scared. But there are certain situations where you really do want to get the best people around operating on these folks because, any kind of big surgery is not going to be easy.
Well, for what it's worth, Ryan, you are one of the best around. So glad that Parkland has you watching over these patients.
To sum it up, you said it very well. I mean, always do the right thing for the patient. Always think logically. Don't be a cowboy. Despite you being in Texas, like if you feel like it's outside of your wheelhouse, stabilize the patient and ask for help. Because at the end of the day, you got to do what's right for the patient. Like torsion comes in, it's 2:00 in the morning. You don't want to lose sleep for your next busier day. Wake up,
do the right thing. Go in and fix it and then go back to sleep. And you'll sleep like a baby.
Exactly.
I promise.
Exactly.
Well, I think both Arthi and I want to thank you for everything you taught us when we were your residents, but also for your time that you've given us for this podcast. We really appreciate your insight as an adult practitioner.
It was an honor being able to help train you guys, and now you're out there killing it, and I'm really proud, just like I am of all the residents. I feel lucky to get to teach some of the smartest people out there. Every day I get to work with smart people.
Ryan, it was such a pleasure being able to be one of your residents, and we're so, so glad that we were able to chat with you today.
All right, thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.